The next talk by Dr. Anil Radhakrishnan on optimizing ocular surface during phacoemulsification.
Thank you, Sandhya. I think this session deserves the special mention in that you have taken multiple specialists and brought it in one umbrella. It's a very good session. So I think I think pterygia, obviously you have to take it out before you do cataract surgery. But when should we take out the pterygia? It depends on how much it affects the cornea. So if it is only a small atrophic pterygium right in the periphery, you don't have to really bother about it. But if it is affecting your keratometry values, better to take it out. As you see in this patient who had around 6 diopters of astigmatism, and that blue color indicates flattening corresponding to the head of the pterygium. And once you take it out, it's less than 0.75 diopters of astigmatism. So we all are aware of the lacrimal function unit. I think it's a very boring topic, but we know that there is sensory feedback coming from whole of the eye, even the upper part of the nasal cavity that goes right up to the trigeminal nucleus. And from there is some connection with the superior salivatory nucleus, and the efferent pathway goes out through the geniculate ganglion of the facial nerve. There is the parasympathetic outflow that reaches the ciliary ganglion, and it gives information for the lacrimal gland to secrete the tears, both accessory as well as main lacrimal gland. So even at the basic level, you have some amount of reflex tearing that is happening. The sympathetic output is from the superior salivatory ganglion that is also contributing. And we have some things which we are not exactly still very not clear about. I would digress a bit. This is an international association for the study of pain. They define pain as an unpleasant sensory and emotional experience associated with or resembling actual or potential tissue damage. That is important, actual or potential tissue damage. So again, if you look at the pain pathway, the fibers reach the trigeminal ganglion. There are multiple things in the brain. First is the transduction, that is the receptors perceive the pain. Second is transmission to the respective ganglion. If it is the body, it is the dorsal nerve root ganglion. If it is from the eye and the ocular surface, it is to the trigeminal ganglion. At that area itself, there is some modulation of pain that is happening. That is actually working through the cortex. You know, if you can have connections with the thalamus. You have connections with the paralimbic system. You have limbic system is very much involved. And if you have more cortical activity, that is also suppressed. So you can think of people who are really busy. They won't bother so much about the post-cataract dry eye. But people who are basically, I'm just extrapolating, but people who are just sitting at home, they are likely to complain more about it. And that is one thing. First is transduction, second is transmission, third is modulation at the ganglion level, and third is the what is perception. Perception is at the cortical level. From the thalamus, there is connection to the cortex, and a lot of things which we have not really understood. So a lot of things can modulate pain there. And it is also well known that once the pain pathways are activated, that is all very much documented in people who manage chronic pain. When the pain pathways are activated, even if the stimulus is not there, the pain pathways can still keep on running. So you have this A delta which conducts the fast pain. That is when you have a corneal abrasion, you have a sharp pain. That is through the A delta. While the slow pain, you have this dry eye and dysesthesia and all these. These are through C fibers. So in the preoperative planning, if you have a topography like this, you see some red thing in this thing, you have to repeat it. You have to put a lubricant and repeat it, and it should be normal most of the time. That is because of a random dry spot that occurs on the cornea. The problem with that is if you have dry spots on the cornea, that can interfere with the keratometry. And sometimes if you are going for a toric intraocular lens, as you see in this patient, there can be significant difference in the lens power that you calculate. So whenever you see a patient in the clinic, you have to see the patient under slit lamp. It's not just enough to see under a diffuse illumination like this. When you think a bit of redness is there, it can indicate dry eye. You have to look at the parallelepiped image. You can see these small white spots under the fluorescent, and that tells you that there is some punctate erosions. Then punctate erosions will not happen unless the patient has dry eye. It is not possible to have punctate erosions. So whenever you have punctate erosions, you have to treat the dry eye and then only take up the patient for surgery. Otherwise, you are going to have an irritated patient. it makes sense to do a tear breakup time in all the patients, So I don't think I expect everyone to do dry eye workup and all that. Just put a drop of fluorescent and look at the tear film breaking pattern. So if you see a random spot which happens very fast within 4-5 seconds, normal time tear breakup time they say is in about 10 seconds. If you see the tear breakup is happening within 4-5 seconds, you know that there is a moment of dry eye, which is very common in urban population. So that has to be taken into consideration before you take the patient for cataract surgery. So if it is abnormal, you have to do a thorough evaluation. You have to do Shermer's, you have to do other things. But generally, just put a drop of fluorescent and have a look at the patient under slit lamp. That's all what you want. There are a lot of drugs, especially in the population that we do cataract surgery, which can cause dry eye, antidepressants, antihistaminics. Among the BP lowering drugs, beta blockers are notorious, but nowadays people are not very much using beta blockers. This losartan and stuff like that, it does not cause. Calcium channel blockers are actually helpful. If you have long-term diabetes, there can be some amount of diabetic neuropathy, and that can contribute to dryness. And if you have a connective tissue disorder, obviously you have to work up and make sure that things are stable before you touch the patient. So there are a lot of investigations which I'm not going into. But is dry eye common? It is pretty common. I think if you look at a meta-analysis of 9 studies which are non-industry based, we see that about 37.4% develop dry eye after cataract surgery. There are a lot of factors which are involved. I think I'll come into that later. So before we go that, just a glance of the cornea, we have a very prominent subbasal plexus in the cornea. Cornea is the most sensitive structure in the human body. Our periocular skin, if it has X, cornea has 300X or minimum 100X the time of sensitivity that it has. It is about 4,000 nerve terminals per square millimeter and is exquisitely sensitive. So any cut in the corneal nerve, there will be some amount of dysesthesia. As you know, in LASIK, after LASIK, it takes almost 6 months for the corneal sensitivity to come back to normal. After keratoplasty, you see anesthetic cornea for up to 1 year. And in cataract surgery, generally about 1 month, you will have dryness. At around 1 month, near about 25 days, you will have these neurite cells. Do I have 1 more minute? Yeah. At the end of 1 month, you have these neurite cells, and there is increase in the neural growth factors that are seen in the 25 days post-op, and that contributes to the symptoms that the patient has. So in the interest of time, I'll just say that cataract surgery causes sensory nerve damage at the incision, even though the incision is very small, and because of the less blinking, that also can contribute to the dry eye. So the factors that can contribute to the perioperative dry eye in the perioperative setting is, one is the type of procedure. If it is a large extracapsular or an SICS, you can have more dry eye, obviously. The type of drugs that you use, if you keep on putting this dilating drops every 5 minutes, you can have more dry eye damage. If you have the more like exposure, if you generally we tend to see very clearly, we put high illumination, basically it strains your eye as well as it can cause dry eye. Coexistence disorders like especially rheumatoid arthritis and stuff like that can cause secondary Sjogren's and can cause dry eye. And there is some evidence that cumulative dissipated energy during phaco also contributes to the dry eye. So I repeat, TBT and corneal staining is the only thing that you have to see. So if you have got mild dry eye, it makes sense to use artificial tears minimum pre-operatively at least 2 weeks before the procedure. Ideally 1 month before the procedure. It's better to use a dual acting agent, and hyaluronic acid is the one that is preferred, or you can use a combination of HP GOR plus a polypropylene glycol or polyethylene glycol. So if you can combine trehalose with hyaluronic acid, it's more beneficial. It takes almost 1 month for the sins to improve, and if you're giving omega-3 fatty acids, we have to give it for at least 1 month. So this is a study which compares basically 3 different groups. One group in which the dry eye, only routine post-operative medications were used. That means antibiotic and steroids were used. They had a speed score of 1.25. And group B in which they used dry eye medications after surgery, and group 3 in which it was pre-operatively used. If you see that the speed scores are less in people in whom pre-operative medications are used. I think most of these studies are industry sponsored, but still there are some data which says that preoperative usage is helpful in quite a few patients. So I'll sum it up saying that if you have a patient with dry eye, as much as possible to go for a smaller incision. Consider avoiding astigmatic keratotomy. Then limit the drops. Don't put dilating drops in NSAIDs if at all. Then use preservative-free drops as much as possible. Reduce the amount of illumination that you use. Make it minimum as comfortable to you. Limit the surgical time. That is again very important. Then reduce the surgical trauma. As if in femtosecond laser, if you have the suction rings on the limbus, that can also lead on to dry eye. And if you have moderate to severe dry eye, you have to treat it more vigorously with autologous serum and other stuff. And if you people even in advanced dry eye like Steven Johnson syndrome, it is possible you can do a punctal plug and improve the tear volume and then do a cataract surgery. You should also realize that in SJS, the meibomian glands are almost not there. So you have to use some agent which has lipid also in that. I think in the interest of time, I'll wind up. So cataract surgery is something that causes dry eye, and the treatment of dry eye is demanding. And optimization of ocular surface is very important to ensure a surgical outcome. Thank you.
Thank you, Dr. Anil. I have just one question. When you're treating a patient for dry eye, when will you consider cataract surgery in that patient?
Okay, so I think it depends on the dry eye that you are going to treat. Like if it's an established Sjogren syndrome and all that, get the inflammatory parameters under control, ESR and CRP. And as I said, the tear breakup time and fluorescent staining, if you try to reduce it by putting the patient on cyclosporin, use it for minimum 1 month, ideally up to 3 months, minimum 1 month. Usually by that time, along with the regular hyaluronic acid and all that, it will improve, and then take the patient for surgery. So 1 month, it's very difficult now that we have very great competition, especially in places like Kochi. But at least 15 days, try to push the patient and then do cataract surgery.